Before today's episode, I want to ask for your interest. We'd like to open our Keep It Real episodes up to you, the listener, and have discussions on topics driven by the content of this podcast and our social media. If you're interested, we'd love to hear so by dropping us a message on our Instagram. Our handle is ResilientPPT, ResilientPPT. Thanks.
Welcome to the Resilient Performance Podcast. I'm your host, Doug Kachidran, and today I'm joined by Jared Boyd. Jared is a board-certified sports physical therapist, where he is currently serving as a performance therapist for the Memphis Grizzlies of the NBA. He has performed clinical rotations at the University of Tennessee, United States Air Force Academy, and Exos. His practice revolves around addressing biomechanical and neurophysiological patterns to positively influence performance and construct effective reconditioning continuums with a significant emphasis on psychosocial and contextual factors that influence the pain experience. As a clinician, his goal is to facilitate a return to activity and enhance patients' potential by identifying opportunities to increase resiliency and empowering them with strategies to perform for life. Jared and I discussed what it was like to transition from a traditional outpatient sports physio setting to the NBA. There are benefits and drawbacks to each setting. We also discussed areas in which performance staffs can truly make a difference. With the emphasis on dynamic correspondence and skill acquisition in the field, it can be easy to forget the qualities that strength coaches and physios can actually modify in a relevant and quantifiable way. Additionally, Jared shares what data and key performance indicators he uses to influence his clinical decision-making.
Hey, Jared, thank you so much for coming on. There's a lot of stuff. We've been talking offline for a while, so I wanted to get going with the recording here. But can you begin by talking about, we're going to get into kind of your journey as a clinician, but just start by talking about, you're a physical therapist and a certified athletic trainer. What's kind of the overlap between those two professions, and because I know that sequentially you started out as an ATC first. What kind of made you decide after, getting your ATC to get into PT? Because there's seemingly a lot of overlap. And I think that you and I probably both know athletic trainers and PTs that we would consider somewhat interchangeable. So, and I think that there should be actually more collaboration between those two professions. Having done both, can you kind of speak to what that experience was like?
Oh, absolutely. I think, for me, I was lucky in that I had an opportunity to actually have both of those degrees coincide with each other at the same time. So I went to Shenandoah University in Virginia, and it was a dual degree program where I was able to get my master's in athletic training and then the doctorate in physical therapy simultaneously with overlap in regard to the classes. So for me, it was great because I was really able to see the juxtaposition between the two professions, but also the things that really coincided with each other. And so when I think back on, my experience specifically, I think the positive for me was that my professors for athletic training were all PTs as well. So every athletic trainer professor were also physical therapists, and they all had their CSCS. So they all had this reconditioning kind of performance, strength and conditioning, if you will, background. So they were really able to kind of marry that into the curriculum. And so the athletic training courses actually started a semester prior to physical therapy courses. And so I was able to kind of entrench myself in a better understanding of what movement and musculoskeletal rehab really looks like prior to physical therapy courses starting. But then even when I really take another step back and say, well, what is the big difference? Because as you stated, there is a lot of overlap in regard to what both entities are able to do from plinth to play or table to turf from a reconditioning perspective. But I think the big delineation for me was learning and being more equipped with the ability to triage injuries when they first happen. So looking at things that were a little bit more traumatic or things that we had to determine whether or not this warranted a little bit more further investigation from perhaps an imaging standpoint or some kind of surgical procedure, or determining whether or not this athlete is able to actually go back onto the field or to practice right here today. So, in physical therapy school, I don't think we're really equipped to discern that as much. I know that curriculums are steadily and always evolving and updating, but I think the big delineation for me was just the ability to feel a little bit more comfortable if someone came off of the court, the field, whatever it may be, and they had some kind of an injury, and having the skill set to understand what tests are going to be maybe a little bit more appropriate to use in order for me to discern whether or not this individual has the necessary capacity or requirements to return to play. Again, not saying that physical therapists don't have the capacity to do so either, but that's probably the biggest delineation. And then I would even venture to say, and maybe this is just my particular experience, but maybe like that later stage reconditioning or rehab. As I said, I felt comfortable in that I was equipped with the knowledge and experience to gain those skills with athletic training. But physical therapy, and then some of my just personal clinical experiences in physical therapy school probably allowed me to ascertain those skills a little bit more than athletic training. So like those end stage reconditioning kind of programs and periodization schemes, if you will, which again, even with physical therapy, I'm saying, yes, I got that more there than AT, but a lot of those even just came from personal readings and outside resources as well, because physical therapy school is really just about making you more of this generalist, and you have the ability to traverse any domain, whether it be neuro rehab or geriatric or sports, and obviously it's up to the individual to kind of immerse themselves further in whatever kind of field they're looking to get into. So those are kind of like the big delineations, and admittedly for me, it's right now, and really ever since a lot of my clinicals, I haven't really practiced as an athletic trainer. So, I mean, if somebody said, hey, you're going to be the head athletic trainer right now, and it's your responsibility to go out and do X, Y, Z, I'm not sure if I'm the most equipped to be able to do that. But there are, just because of the fact that it takes a lot of repetitions, and it takes a lot of exposures to seeing different things and understanding some of the nuances of how to handle even things that are really minor, how to handle those occurrences and those instances.
Yeah, I didn't realize that you had pursued the ATC and the PT degree congruently. I'm pretty sure now, and correct me if I'm wrong, that the ATC path is a master's program. But at one point, I think you could get your ATC as an undergrad. So, people would often ask, like, what do you think is the best undergraduate route to go before getting into a performance type field or even physical therapy? And I always thought, at least while it was an undergraduate degree, ATC was the way to go, because you have this versatile skill set where I think that there are, even though kind of like the as you sort of validated, like the assumption is that ATCs cater to more of like the acute end of things. I think that there are probably more ATCs that are competent at end stage rehab than there are PTs that are competent at the acute traumatic type care. So I think that, like, overall, like it may sound sacrilegious, I think ATs might have, the good ones at least, a broader skill set than many of the PTs. So like if you get this ATC credential as an undergrad, you can always still go to PT school, but now you've graduated where you've got a clinical degree that's somewhat versatile. You can segue that into performance and get like a CSCS, or get more into the strength and conditioning side of things. So, and now with that being a master's degree, it kind of changes that calculus, because I think, and you've probably seen this, a lot of people always ask, like, should I go to PT school? And with the amount of debt and time involved, that's a difficult decision. And I feel like when there was an undergraduate ATC credential, I would tell most people, like, why don't you get your ATC first and see if that gets you where you want to go before you make that kind of commitment. But I think it's cool that you had that dual program. I didn't even realize there were that many of those. So were you doing that? Was it like when you, after undergrad, that you did that? Or was it one of those, like, say, 6-year programs where you're getting your undergraduate and your DPT? How did that work?
Yeah, so for me, it was kind of wild, because I went to undergrad at VCU, Virginia Commonwealth University, and I had about, I want to say maybe 1 to 2 weeks off once I had graduated undergrad, and then I started at Shenandoah University in the athletic training program for that summer. So it went from maybe May or June until August, and then once August came around, then I started the physical therapy classes. But they also again coincided with the athletic training classes as well. So those then became a little bit more of like our online didactic classes for athletic training. But we also had clinical rotations. So we would go to physical therapy school. We would be in class from whatever time it was, 8 or 9 until 3 or 4. And then the people that were dual degree majors, AT and PT, would then go to their delegated high schools to do their clinical rotations. So you would be there covering the sports from 4 or 5 to 8 or 9, depending on if there was a game. And then you would go home, and then you would have your work to do, whether it was for PT or your online classes for AT. So it was a lot of work. But again, in hindsight, it's like though that experience, I think, is what allowed me to have maybe a little bit more of this organizational skill set and be a little bit better in regard to prioritizing time and understanding where I was allocating my resources.
So obviously, like, because you were in a DPT program, they want to prepare you for the boards and give you that kind of generalist education. Did you find that because you were pursuing your ATC at the same time, that maybe they took a little more shortcuts with like the neuro and the cardio pulm stuff? I mean, obviously they had to meet the criteria. Was there less of that than maybe there would be at a more traditional DPT program because you were also pursuing that ATC congruently?
Yeah. Oh man, that's a great question. I would say for us, just because of the fact that they only allowed five students to enter into both programs simultaneously. Okay. And so the curriculum stayed the same for the entire cohort of each individual class, AT and PT. And so we were still really equipped and inundated with information, robust information for every single course, whether it was, like you said, neuroanatomy or whether it was pediatrics. So we still were able to, I think, get a good grasp on all the education and information that we needed for the boards. Now, that's not to say that I remember it all now, but more so just because of the kind of domain that I'm immersed in currently.
Okay, so you just basically have to do more work than everybody else to do both at the same time.
Absolutely, oh, for sure.
Yeah. So you talked about this breadth of education, and now I want to get to you're in the NBA working as a physical therapist. But prior to that, you had mentioned when we spoke off the air that you were working in a traditional outpatient clinic that wasn't the best fit for you right after you graduated PT school, and then you ended up at Rehab to Perform. And I want to give those folks a plug. Just because, as I mentioned to you, I feel like not that this is a real life scenario because students are allowed more than one clinical rotation, but if a student asked me, I'm only allowed one clinical rotation and I want to get into this performance-based physical therapy, what would be the best place to go? I would say without any kind of hesitation, it would be Rehab to Perform. And I would even pick them over our own clinic because I think that they see, a little bit more post-ops than we see, and they're seeing a wider range of patients than we are. And they're also working in an in-network model, which I think is very important as well, because that's more real life. And I think that you need to work in real life before you work in kind of fantasy land. So I have a ton of respect for Josh, for what he's built, and for all the clinicians there, because you just have a ton of high quality people there. So you end up at Rehab to Perform, and you're working in this, in a very robust outpatient sports setting. I think that their model, they're doing it as well as can possibly be done considering those insurance constraints. Then you end up in the NBA where you're not, obviously now you're working with maybe a team of 15 people and you might not even have all 15 of those athletes assigned to you. So what would you say is, like, in terms of your development, the upside and the downside of working in that more traditional outpatient PT setting where you're getting a ton of reps, seeing maybe like a broad range of injuries, becoming that generalist? And now you're really, more of a specialist working with a very unique type of athlete, but you're not getting a ton of reps. Do you find that, like, there's certain things that you have to do to kind of stay sharp clinically because you're not getting as many reps? Like, how do you kind of reconcile the pros and cons of both of those settings, considering where you are right now?
Yeah, I would say, it's an excellent question. For me, It's something that I think about a lot because it's one of those things where I want to make sure that I don't have some of those skills stripped from me because of the fact that I don't have to use them at a frequent basis as much as I did when I was in an outpatient orthopedic physical therapy clinic. And so, you know, one thing I think about is at an outpatient physical therapy clinic, for the most part, the clinician is really autonomous. And that's not to say that we're not autonomous in the sports sector, but what I mean by having more autonomy is that we really are the arbiter of making sure that this individual is, starting from day one, post-op, post-surgery, all the way to the point of return into competition. So we're really traversing this entire reconditioning continuum, if you will. And so, I kind of equate it and maybe use an analogy to the fact that if I'm thinking of driving on a road or on a freeway, then I have the ability to move in and out of all these different lanes. There's no lane that is not available to me to merge into. So I could, I could drift over into the lane of being a strength and conditioning coach, drift over into the lane of being a physical therapist, drift over into the lane of being all these different things that allow the athlete or the individual that has some kind of injury that they're getting back from to get back to their activities. As opposed to in the NBA, it's we have a little bit more of like these stringent, if you will, domains and responsibilities and roles. And so, if I'm thinking of driving again on that freeway, it's like perhaps I can merge into that lane, but it's gonna close quicker, right? And there's certain lanes that are restricted to me that I just can't get over anymore because that's not that lane is going to be delegated for someone else, right? And it might be the strength and conditioning coach, or the other lane might be another PT that sees these particular players. And so the biggest thing for me is that I had more of like this horizon or this breadth of patients to be able to see, and a lot of different, not only patients, but pathologies or injuries. And so that was great because it gave me range, and I think you can draw a lot of connections and similarities and really just become a little bit more robust in this generalist. So you can draw parallels in regard to just the manifestation of injuries, if you will. And so that I think was very advantageous and really beneficial because it does lay the architecture for the foundation on which you can kind of build your skills on. But then when you think about the NBA, when you kind of have that, taken away inherently just because of, as you alluded to, you have 15 guys and you have 3 physical therapists and you have the strength coaches and the sports science. It's great because there's tremendous collaboration and these consultations, and you're able to pick other people's brains and have another set of lenses to be able to determine whether or not what you're doing is beneficial and effective. But I think it also allows you the ability to maybe refine your lens, if you will, and not have to be so broad with the terrain in which you're looking. So you can become a little bit more specific and a little bit more, I guess, pragmatic about the selections that you're using, because you have almost like the resources available from like a brain capacity, a cognitive capacity perspective. And outpatient physical therapy, if you're saying, 12, 15, 16 patients a day, it becomes very, very challenging and timely and even costly to really commit to education in every single entity or pathology or injury that you're seeing. And so you become really good at understanding things that are really important, for sure, because you have to get to the low-hanging fruit really quick. But I think this particular path that I'm on right now allows me to kind of perhaps get a little bit more into like the nitty gritty, if you will, to understand a little bit more of like the nuances and what to make of that. And it's also allowed me the ability to continue to get a little bit better at this communication standpoint. And when I say communication, it's really like having this great collaborative effort with every single individual, so that not only can you speak their language, but when you should speak. And so, whatever presentation you're presented with, it's understanding enough about that other person's responsibilities and their roles, so that you know and you can discern whether or not it's important for you to share and impart your information about that particular athlete as well. So you need to know enough so that you understand when the information that you have is critical to the conversation and whether or not this individual should return to play or potentially kind of like pull the reins back a little bit depending on what they're presenting with. So, both have upsides and downsides, and I try to always look at the glass half full, and they both have been really beneficial for me, and both a really growing process in my overall, I guess, matriculation as a clinician.
Yeah, I think it's funny that you mentioned the autonomy that people have in the outpatient setting, because I think a lot of us who kind of work in this like performance, clinician hybrid type role, we romanticize like being this global load manager where we're kind of like connecting all these disciplines. But in pro sports, like there's necessarily always going to be these sub disciplines. And in the outpatient physical therapy setting, like the people that I work with, I'm not working with like generally elite athletes. Like I'm their physical therapist, I'm their strength coach, I'm their track coach if they're a track athlete. And I actually kind of enjoy being all those things. But if I was working with a world-class sprinter, like I would have no business programming, how an elite sprinter was like what they were doing for their block start volume, right? Like I'm comfortable working with like a team sport athlete, even a high level team sport athlete on like, running programming. But if it's like an elite track athlete, necessarily there's only so much expertise to go around, and there's actually a lot of constraints working in pro sports is a great job, but people I think tend to not like talk about like some of the constraints that you all work under, and in some ways those constraints are good because they allow the different people on the staff to utilize their expertise, but it comes at the cost of that autonomy. So it's not that one is better or worse, because I'm not going to do all those disciplines as well as having a world-class staff like you have, where you have a world-class strength and conditioning coach, world-class clinicians, and world-class sport and technical coach. In the outpatient PT setting, for the most part, I kind of have to wear all those hats and I enjoy it, but I think that the ideal actually is just to have, good communication, good leadership, and then be in the situation that you're in, where you just have people that are, trying to integrate these skill sets, but in a team setting.
100%, and the fact that everybody wants to grow and wants to understand each other's perspectives, and so that allows you to update your beliefs and information about a particular topic, so that you can refine that, and then as a consequence, you can update your actions and your action plans, so that if you ever left that particular domain, then you now have even more additive information to then back up future interventions.
Yeah, and I'm curious about what the transition was like going from that outpatient setting to the NBA, because you mentioned, you're seeing like that generalist, that range of patient population, range of injuries. So, there's the argument that like people are people and nothing is really that new, but you're also working with a very unique population of people.
Yeah.
A very small subspecialty of the clinical population. So did anything surprise you clinically? I mean, even having gone through that very like extensive breadth of experience in the outpatient setting, or was it, or
Yeah.
were you kind of taken aback just because of the uniqueness of some of these athletes?
I would say that the thing that maybe not surprised me per se, and maybe some of this is predicated on what you were talking about in regard to, oh, well, we're all just humans and we all are made of the same tissues. But, I think I initially failed to realize that height plays a major role in the forces that are going to incur on the body. And so, when I say that, I just think about like the levers and the lever arms. And so I think about that coinciding with the rigor of the demands from a basketball standpoint of, hey, the amount of force and forces that they're going to be exposed to are going to be exponential. And when you layer on top of that their mass, their height, and so it's like their momentum, right, their force and the velocity at which they're moving at is going to be really high. But not only is their momentum high in this particular sport, it's the amount of accelerations and decelerations and changes of directions that are required for them to be successful and skillful. They're not really ever hitting top end speed. So it's like well, they get a lot of accelerations and these decelerations. They have to change direction, so they have to impart a lot of impulse to quickly decelerate and reorient and redirect that force or change that momentum. That's a high magnitude forces. But not only that, but the rate at which those magnitude of forces are occurring is incredibly high. And we understand too, if we layer on top of that, like this concept of stiffness, and that, we're trying to maybe mitigate or lessen the degree of excursion because I have to quickly change direction. So I don't want a lot of compliance because that might be counterproductive or for me to excel in the particular sport of basketball. So when we think about that, it's like, okay, well, they're probably, that might be one of the reasons and one of the variables as to why they might have more of this proclivity to have these tendon oriented pathologies and pains, and these anterior knee pain as well, or again, even some bone stress injuries as well, because all of these injuries to me, while they might be volume based, right? I think of volume similar to, it was an analogy that Greg Lehman used in regard to in regard to pain. So he looks at structural changes are like kindling, and then you need an accelerant to actually have pain. So I look at volume as being like the kindle, but intensity layered on that is going to be the accelerant that then transfers over to having an actual injury. And so the volume of these repeated cyclical lows and activities and accelerations is going to be kind of like that foundational layer. But then we also have the intensity of that, which is going to be the magnitude and the rate of those accelerations happening over a span of 82 games. And so it's like, well, no wonder they have these types of presentations. And so it's just understanding that while, yes, we're all just humans, they present just because of the actual kind of contingencies of that particular sport, but then also what they're made of. It's really incumbent on the person to really investigate further as to why they present like this, and then what can you do to kind of triage and titrate some of the programming so that we can lessen the degree and the manifestation of some of these pathologies. So I think for me, that was the biggest thing, is just not this concept of just loaded concept that I think floats around a lot. But I think sometimes it's like the pendulum swings too far, and we have to really understand that, well, just loading it won't be enough for this particular population, and not even just this population, but probably any population. I think you have to be very pragmatic and very intellectual about when you say just loaded. Well, what are we considering? The magnitude, the direction, the time or duration, like all those things matter, and physics definitely matter, because that's going to be what imparts a particular type of force through that tissue, or stress through that tissue. And these guys get a lot of stress through certain tissues because of the fact that, for example, like their anterior knee pain, they, as I mentioned earlier, they don't want to get these excursions, and so they're remaining relatively rigid and stiff to reorient their change of direction. And so there's going to be more stress, or like force per unit area at the patellofemoral joint, because it's not getting into those more compliant ranges. And so maybe they perhaps need more compliance, and they need less plyometrics, right, during the season, because they're already getting that. They need the ability to absorb and to be able to allow their quads to dissipate and attenuate force. So it's like just reconceptualizing all those constructs and how that fits into this whole plethora of the dynamics of injury and reconditioning.
Yeah, you kind of alluded to it a little bit talking about some of these tendinopathies, but I wanted to ask, what types of injuries or conditions do you see in the NBA that maybe weren't as common in that traditional outpatient setting?
Yeah, for me, most of what I see is relatively common from where I am now to outpatient. I think there's a lot of parallels to that, but I think the biggest thing is just understanding. When I used to think about tendinopathies, I would say, okay, well, the biggest thing we have to do is make sure that we improve your ability to handle that particular volume, because I would typically see runners. And so it's like, okay, well, volume probably is going to be the instigating factor, or the thing that's kind of irritating the tendon and making you more symptomatic. And so let's maybe reduce volume and then gradually implement the volume back, because that's what you need to be able to handle in order to complete your desired or required activity. Now I'll look at it as, okay, volume is still going to be this variable that we definitely have to consider, and we definitely have to titrate it and get it correct so that you can handle that. But it's also going to be the sprinkled in with the intensity, because as I mentioned, like their mass and the force that they're going to be going through places an extreme amount of force and load through the tendon. So they need to be able to handle that intensity or that rate of force over a sustained duration of time, over so many practices, as well as maybe 3 games a week. So it allowed me to maybe peel back the layer and say it's not just this one thing. I have to be a little bit more broad about how I'm approaching this, and making sure that I'm looking at every potential variable that might be inciting their symptomology, and then understanding, okay, well, if this is the potential impetus, this is then what they're going to have to get back to. And it all goes back to what we mentioned earlier, of like just this collaboration with everybody involved in that particular case, because you don't have to have all the answers.
Yeah, and I mean, this is going to be a hard question, but we all want to know what our value is, and what it is that like we actually do with athletes. What kinds of injuries in your setting do you think that people like us can actually influence or mitigate the risk of? And I ask because, like when people on the outside evaluate like the effectiveness of a performance staff or a sports medicine staff, like a commonly used metric is, games lost to injury. But if you have bad luck and like one player tears an ACL the first game of the season, now that's like 82 games lost to injury. And like you could lead the league based on like a totally freak thing. And even if it was non-contact, it's like, well, did they step on somebody's shoe? That's technically non-contact. I mean, what do you think it is that we can actually influence for the better, even if it's like you can't back it up with objective data and it's more your intuition? Because I'm actually kind of intrigued by your experience in this setting.
I would say, man, I like that question. If I think about this, I would probably say that maybe more of our contractile-oriented tissue pathology. So more of these strains are probably things that we have a little bit more leverage on, and there's a little bit more levers to maybe modify the risk of those tissues being exposed to too much stress and having pain or injury. And so, especially when you think about when you think about the interventions that you can implement for that particular pathology, but also the objective testing that coincides with it. So those are like, when I think about trying to mitigate or reduce the susceptibility of injury, it's like, well, what's an intervention that has pretty good efficacy and utility, but then am I able to have any kind of objective criteria to discern whether or not my intervention was beneficial? And so things like muscle strains, I mean, typically there's going to be, obviously when we think about those, it's adding a mechanical stress to create this mechanical transduction for this tissue to handle a particular amount of stress at a particular magnitude in a certain direction. But then we have testing that we could do, whether it's isokinetic, whether it's isometric testing, and then we can compare that from limb to limb to discern whether or not they have a viable amount of force production that's needed for them to be successful with that sport. And so that's why I would say more of like those contractile-oriented issues, as opposed to more of these inert, because those typically are going to be contingent on some kind of trauma or some kind of very, as you mentioned, maybe like these just freak accidents that kind of happen. And now people, in hindsight, we can always use post hoc and say, oh, well, this is the reason why it happened. So it's definitely easy to do that. But those are a little bit more challenging to predict. Everything is challenging to predict, but I think those maybe are a little bit more challenging to really try to reduce the susceptibility of happening in the future. And then probably even with the contractile, I would probably lump in with that tendon issues if we have this very logical progression into loads, whether it be, again, those intensities and those volumes, things that if we can manipulate those variables and make sure that we're not doing too much too soon, having this logical progression into graded exposure, then typically this concept of physical stress theory, we shouldn't have poured too much stress into their stress bucket. And so now they have enough reserve to be able to handle the duration and the frequency of the games.
Yeah, and you mentioned kind of this emphasis on like training muscles, and I talked to one of your colleagues recently about like the layout of your weight room, and he mentioned that there's like a lot more machines than there were a couple of years ago, and even things that look more like bodybuilding type training. A lot of the protocols that your team utilizes look almost like bodybuilding type, not that you can never like really isolate a muscle, but not to say that you don't do compound movements. But it's funny because you've been very outspoken about like the importance of language. And then we always hear this term in our field, functional. And I'm curious to hear your thoughts, in the context of what is functional for your sport, because you talk about how like the things that are actually really trainable might be like the ability of, developing quad strength to reduce quad strains, reduce the potential for things like patellar tendinopathies. And sometimes the way to develop that is not in what we would associate as being a functional movement, like a squat or a deadlift, or even like a rear foot elevated split squat, but something that looks more like what a bodybuilder would do. And, part of me, even like 2 or 3 years ago, would have had a visceral reaction to like an athlete doing a leg extension. But now, especially because of people like you and your staff members have made the case that like this is actually, it makes total sense. So how do we talk about something like functional, and what is the role of kind of more of these like isolated bodybuilding type routines in the NBA, where you have people that are just so freakishly athletic to begin with? It's like, again, it makes sense now because I'm like, what can you and I really do to make these people more athletic? But if we can target a particular tissue that might be like a weak link in the chain, or something that just because of the nature of the sport takes a ton of abuse, and make that like bucket bigger, so to speak, like you mentioned, maybe like a bodybuilding type protocol or exercise is more functional. So can you get kind of more into that? Because I think in some ways, like your staff is at the forefront of that.
Yeah. So, when I take a step back and I think about the word function, which is probably relatively nebulous and like ambiguous, because everybody has their own subjective definition of what functional means. And I think that's why we get into like these tribal debates, especially on social media. But I would say, at the basic level, function to me is an exercise or a movement or activity that will function to prepare the individual to perform the desired and required activities. And so what I think that happens is that there's this false logic in regard to thinking that functional means dynamic correspondence or representativeness. And so people will have this tendency to say, if this particular movement or exercise doesn't resemble directly the activities and the demands that the individual are going to be exposed to, then it's not functional. So therefore it's irrelevant. And sometimes what happens is that these movements that are representative, meaning they do look like what happens in the sport, they actually might not be that functional. And so what I mean by that is if for example, we have someone that's returning with ACL reconstruction, and we want to do some integrated compound movement, and we select to do a squat because we say, hey, it's functional, it's representative, it has that dynamic correspondence because they have to get into a squat position on the court. Well, if they haven't regained the basal level constituent of their quad peak force production, nor their quad rate of torque production either, then that exercise might not be that functional. Yes, it's representative because they get into these squat kind of positions, so to speak, but they could find a way to deviate because they might be averse to loading it, maybe due to subjective symptoms of discomfort and pain, or because they just don't have the capacity to integrate the isolated tissue in a manner that emerges as something that we think is sufficient from a movement standpoint. And so we could then say, well, if we take a step back, what would actually be more functional? What would really serve as being able to aid in the function of this organism being able to meet their demands of their activity? Maybe it is a constrained, isolated activity like a leg extension, because it allows us the ability to really accumulate load to that specific tissue and minimize the complexity of the task. So now, not only do we reduce the cognitive load on that individual to organize against gravity, but we also make sure that it's going to be more of a challenging time to try to navigate around and be averse to loading that tissue. So we can ensure ourselves that the tissue that we're trying to expose to some stimulus to warrant an adaptation, be it hypertrophy or strength, is going to gain those adaptations. And so I think we leave a lot on the table, when we talk about things having to look exactly and resemble the direct sport, because then things just start to look silly and relatively superfluous. And then it's like, well, you can't even load. It might look like what they're doing in their sport, but you can't load it to a degree that's sufficient enough to warrant any kind of adaptation. Because there's too many degrees of freedom potentially that are available. So that's kind of what I think about in regard to function. And then, it's like, whether it's rehab or whether it's just training in general, looking at it from like this tier system of, what is the end goal and why are we choosing that modality? Because I look at exercise as like a modality or like a utensil. There's a lot of different utensils you can choose. You can use chopsticks, you can use a knife, you can use a fork or spoon, but it's all going to be contingent on your capability. So are you competent enough to use the chopsticks or use the fork or use the knife in order to do what's necessary, which is to feed yourself in order to grow or provide your body with nutrition? And so the same can be said for using and looking at exercise and implements as simply modalities or utensils. Some of them might not be feasible for certain people based off of their ability to be competent with that particular modality. So maybe let's change it so that we can actually do what we need to do, which is to load that tissue, because we think that tissue, based off of our objective criteria and testing, what have you, feel as though that is going to be a necessary training stimulus for them to be productive and maybe try to reduce their likelihood of injury. And so that's kind of how I wrap my head around this whole functional representativeness as well as these machines. And the last thing I'll say too is, which may be a little bit more challenging to really define, but it's this word of efficient. And so I think of efficient as like, what's the cost of doing business? Everything has a cost. It might be objectively challenging to determine the cost, but all in all, a lot of times these isolated or machine-oriented exercises that are constrained would probably have a less cost on the central nervous system, say as maybe something like a deadlift or a back squat, because there's going to be more things involved in order to organize, again, not just physically, but also cognitively. So it's understanding, hey, what's the cost of doing business? How much am I having to pay in order to achieve this stimulus? So like the stimulus fatigue ratio, and it's like, is the tissue or is this particular parameter evolving and adapting? And then does the athlete still have enough in their reserve to do what they really need to do, which is play basketball? So if they don't have enough to do what they need to do and endure the stressors and the rigors of basketball, it's probably that the cost of that exercise was not worth it, because they're not able to continue to play. And that's at the end of the day, like, that's the biggest goal.
Yeah, I think that's a great summary. And backtracking to what you said earlier about the just load it kind of not being really a comprehensive rehab paradigm, I think that just load it sort of suggests that people are chronically underloaded, and that if we just load them more, it's going to make things better. And I don't think lack of loading is the problem in the NBA, right? With the schedule that your athletes have. But you mentioned the degrees of freedom, and training on a machine with less constraints actually allows you to load whatever it is you want to load in a much more judicious manner, more purposefully. Like what tissues do you want to target? It's much easier to target a particular tissue when there aren't as many constraints. So I think that from like a tendinopathy standpoint, it makes great sense. And even now, at one point the research was saying like you only want to do eccentrics. And then it was like, well, if the eccentrics exacerbate your symptoms, now it's isometrics. And if we look at like what kind of bodybuilders do who are considered like non-functional, they are doing a range of contraction types at a range of intensities, and they're using like a lot of variety. So now you're kind of developing, if you're training a muscle, you're training the tendon. Now that tendon is being developed like in a variety of movements where it's not constantly being overloaded in one pattern, where it's being loaded, but it's being loaded in a more distributed way. So, we don't think of those type of protocols now as functional because that style of training has been demonized. And we talk about like machines and how, machines don't work your stabilizer muscles, but and I look at the athletes that you work with and it's like, does somebody who can 360 dunk have a problem with stabilization? Like, are we going to make, that athlete better or more skilled because they're doing a barbell squat versus a hack squat machine when they can 360 dunk? And are we going to rob them of athleticism and skill because they're working a quote unquote fixed pattern of movement and not challenging their stabilizers? I think thanks to people like you, that's challenged my thought process, because it's very easy to be kind of seduced by that idea that like, oh, we've always got to train athleticism. And I'm not saying there isn't a place for compound movements, and that I don't do them and that I wouldn't do them with your population. And the other thing to consider is, what's the max contract in the NBA now? Like $40 million a year. You talk about like efficiency and upside, downside. If I was working with somebody that made $40 million a year, and I haven't really seen too many guys like blow their backs out hack squatting, but I have back squatting, like that's going to enter into my mind, because like athletes, if they're going to get hurt, should be getting hurt on the court or in the field of play, not in the weight room. So I don't know. I mean, like from a risk mitigation standpoint, do you ever think about that? Like, and even you mentioned the cognitive load, like what they're doing is so cognitively and technically sophisticated. Do we need to exhaust like mental real estate to learn like a movement that takes more than like 30 seconds to demonstrate, right? Like, I don't know. What are your thoughts on that?
Oh man, I'm right there with you. I think a lot of it is based off of us as clinicians, practitioners, strength coaches, what have you, of like this cognitive bias of the status quo bias. So it's like, oh, well, the status quo is that functional training has to be representative and it has to look like this. And functional training is the thing that we have to do now. Or I took this course that talked about claims that said functional training is the best thing to do. So now we have this like the sunk cost fallacy. Oh, well, I spent this money on this course, so now I have to then say that functional training is the best. And so I think a lot of the things that people proclaim and that they do is really going to be predicated on their beliefs, and those beliefs really come from who they surround themselves, who they surround themselves by, and what information they're being disseminated. And so that then becomes the premise behind most of their interventions and how they see reconditioning or therapy. And so, I'm with you in regard to being able to just like take a step back and understand like there's a spectrum, there's a time and a place. And, this isn't saying that, oh, this is the only way and this is the best way, but it's a way that might be sufficient for these particular players. But understanding through it all, it's like being less confident, if you will, in your capacity to change someone's skill acquisition and someone's movement. It's like that's so emergent and so dependent on a multitude of different stimulus. I mean, when we talk about dynamic systems theory and we have all the task, organism, and environment, and we forget that, I think we forget that sometimes, and that they're all like, it's just a confluence. This movement is a confluence of all those variables. And so for us, it's like, what can we actually control? What can we actually manipulate? And to an extent, what can we measure? And what do they potentially not have at a lower level? And then perhaps that will emerge in that dynamic systems movement output. But saying that, oh, I have the ability to specifically train that or make them jump higher. It's like, well, do they really need that? Or is our number one goal and responsibility to make sure that they're available for the duration of the season? How long do they, and longevity, so how long do they want their career to last, and then being able to allocate our resources to things that are a little bit more effective and beneficial in the long run is probably a little bit more of a effective way to approach this rehab thing. And then the last thing that I wanted to say is because you mentioned how people will look at the research and say the research shows this and shows that in regard to like the tendinopathy training, and everyone's like, okay, well, I have to do eccentrics, or I have to do concentrics, or I have to do isometrics. Yeah. And the way that, lately I've been, and we kind of talked about this offline too, of how a lot of times people will now look at research and be like these, I call them like evidence pundits, if you will. And so it's like, well, I think we should look at literature and evidence as like a flashlight, and the flashlight is being used in a pitch black house that you've never been in. And so it's like, yeah, it can shine a light on some things and it can help me navigate my way, but it's going to miss some stuff. And I'm still going to bump into some things, have to, stick my hand out to feel around, to navigate myself and use my perceptions as well. And so I liken that to research, and that, one article isn't going to illuminate every single thing. It's not going to show you everything. You still have to use your own perceptions and your own heuristics, and then simultaneously, yes, coincide the research with that, but understanding that research is just a flashlight. It's not like this huge light that's going to be shed on every single thing, and now you have the answer.
Yeah, and I totally agree with you on like the kind of misplaced faith in evidence, if you want to call it that. I think that sometimes it just becomes a way to like end a conversation, to just say like, it's like saying, like anything that has science after it is probably not that scientific. It's more like signaling. And people who talk about evidence, it's like, let the evidence speak for itself. But at this, so when it comes to some of that stuff, I'm totally on board. And I've written a lot about the sort of like, the limitations of that thinking that way. But we also, people like you and I have to audit ourselves, because what we just said like sounds perfectly logical to us, and maybe it is logical, and maybe it is the right way to do things. Maybe it's not. Internally, if you can talk about it, if it's not proprietary, like what metrics or KPIs do you use as a staff to actually influence your decision making? What are the things that you actually like care about changing, and that that actually influence like, all right, what I'm going to do next, if you can say?
Yeah. So with that, even even just looking at I like this question because it makes me think even more about how, before I got here, I had this, I guess, misconception or this jaded thought process, in that, oh, well, I've read an abundance of research and literature and looked at team sports prior to even coming to team sports, because I always had an interest in it. And it looks like these are all the different metrics and data points that you can use, and it's so robust, and there's a lot that you can collect. So I would imagine that every single team is going to be collecting all this, and they have an abundance of resources, and the infrastructure and logistics don't really matter because everything is available. But then you have to understand, once you're in this domain of like, what are all the nuances, and what are the contextual factors that may impede you from being able to administer or collect this particular data, or is that data now relevant once you really understand some of the other subtleties within that sport or within individuals. So it's understanding like what actually matters, not only to you, but I think there's also a level of what matters and what can you use to have a conversation with the players and the athletes as well, because you want to make sure that it carries over and they're aware, and they can hopefully over time adopt different behaviors. Because if what we're collecting doesn't change behavior and output, it probably doesn't really matter, and it doesn't warrant us continuing to go down that route. And so, for me, I think about like there's different domains and entities, and there's a lot of literature on certain factors. But some of the things that I think are relatively feasible, they have decent utility. I think players and athletes, and not even just in this particular field, but in a lot, they can conceptualize the rationale behind it. Would be, for example, if I'm seeing someone that has some kind of symptomology or pain, an easy one would be like a low tolerance test. So like, what's their asterisk sign? So it's like choose some kind of movement And I'm thinking more right now in regard to like readiness, like what is their willingness or tolerance to be able to perform that day? What is their capacity to be able to endure the preparation that we have in place for them from a physical training stressor standpoint? So, I think about, well, what's a low tolerance test? So if somebody comes in with, if they've been having bouts of tendinopathy of the patellar tendon, then I might say, hey, we're going to do a decline slam board single leg squat, and that's going to be a sign of their readiness from a pain standpoint. But then I could also say, okay, well, it's another category. It's going to be their psychology. So an easy way to get a proxy into like how they're feeling is literally just subjective. And I think people fail to understand like the subjective and like the how are you and understanding their mood and their affect and developing these relationships and this rapport is huge. And again, this is something that the literature does support in regard to, yes, there's a lot of objective things we could look at, but the subjective piece is going to be really big as well as in regard to internal readiness proxy for the individual. And then we could look at what is the muscular, if you will, readiness for that individual. You could look at isometric testing, and that's been pretty beneficial for certain key tissues that we think typically undergo a lot of stress for our sport. And then you could also look at like their actual physiology. So whether that be, and again, some of these things are different categories that you don't even have to have like this robust, very expensive metrics or data and technology, but it's like physiology. People nowadays have all kinds of technology with Oura rings and Apple watches. So it's looking at like your HRV or how did you sleep. Again, those things can become extrapolated and they can become these self-fulfilling prophecies too. So you got to be very smart about how you're reading into those. But again, that's just an insight into their physiology, omega wave as well, for potentially some athletes. And then emergent output, like what is their emergent readiness? So that's just a counter movement jump and looking at their eccentric deceleration rate and potentially seeing, how long does it take them to develop to develop force. And so those things can again just give you this overarching, almost like a surrogate of their readiness and their acute fatigue, and then just looking at trends over time. It's hard to put all your eggs in one basket and make one decision. I think it's things that you have to do over an extensive period of time, and you also you have to pair it with the subjective, and again their mood and their affect and how they're coming in. I think marrying all those things together is really vital. So those are just like a few examples that I think aren't even just relegated to this particular domain.
Yeah, it's so interesting because I mean, even the process of deciding what data to collect requires a certain kind of expertise and value judgment. So you almost need to be data driven because if you collect the wrong data, then it's going to lead you astray anyway. And you also have to answer to somebody like, I have complete autonomy where I work. Like no one is saying to me like, how do you evaluate your worth? To me, it's more like, do I get referrals? And it's kind of like more the free market decides that. It's not perfect, but for what I do, that's kind of like, people keep coming. I'm presumably doing a good job. But for you, I mean, you have to answer to like a GM and a head coach. And it's like, hey, how do I know this guy's knee's getting better? And you can't just say like, well, why don't you go ask the athlete how he feels? They're going to demand a lot more of you than that. So it's hard because you're trying to, reduce this very complex process of rehab that accounts for so many variables into like, all right, well, I'm doing isometrics, I'm doing this. You're obviously doing a lot more than that in your process, but at some point someone's going to say like, how do you really know? What are the 4 things that you're focused on? Because the things that that entire process is going to influence and provide a snapshot of something that's much more encompassing. So again, you're in a very tough situation because, there's so many variables and you have a lot of constraints under which you have to work. And data, I think, has become like this huge buzzword in pro sports. I don't know if a lot of people really know what to do with it, but it's expected of you. So
absolutely,
yeah.
it definitely is. And it's just, I always try my best to just understand like what really are the controllables and what are the measurables and the things that maybe have the highest utility and that I can do something about then and there. And it's like maybe like delineating again, I'm always looking at things through a lens of a physical therapist. Although I have experience as a strength coach, it's like my priority and my responsibilities here are physical therapy. So it's like, what are these phases of rehab that are very fluid? So what are the phases? But then are there particular exit criteria, or as you mentioned, like these KPIs that coincide with this particular phase that allow me to be justified in my decision making for progressing this individual along this continuum to more challenging, more demanding activities, and understanding like throughout this process, another great way to determine whether or not these individuals are ready is going to be, exposing them back into, and this is something that I wish I would have done even more when I was an outpatient physical therapy, but getting them back to more of these small sided games or more into like these technical sessions as well, where it's less complexity. It's not as chaotic. It's more constrained, and we feed their psychological like stress resilience. Like they feel a little bit more like equipped with being able to handle those things. I think being able to cultivate that optimism is going to be beneficial in allowing them to do some of those games that maybe replicate some of the scenarios that they'll be exposed to, but probably not as challenging, and just scaling it down. That's another way that anybody could probably just start to, I think we could all do a better job at. And that it can become a little challenging and tricky, but I do think that using that particular resource as an intervention point has a lot of different benefits.
Yeah, and all of my questions are selfish. This is a really selfish one because you've influenced my thinking a great deal. What are you personally excited about learning now from a developmental or Con Ed standpoint, and as a team, as an organization, what do you think is kind of like what's going to take your staff to the next level in terms of your ability to mitigate injury risk, and what do you think is kind of like maybe the something that is achievable in sports medicine that we're not quite doing it, but that we're close if we kind of do the right thing, so to speak?
Yeah. So to answer your last question about, what we can do better, and I think we definitely have, and there's literature out there, but it's like kind of what I alluded to earlier of looking at load as two different variables, delineating it between volume and intensity, and which injuries are typically associated with those, and is there a particular risk factor or cutoff in regard to the amount of intensity for this particular pathology, or a amount or duration of volume for this said pathology. I think the more data we collect with GPS monitoring and then the sports science side of things, that would probably allow us to advance and reduce the likelihood of certain injuries. Again, understanding that we can't necessarily prevent everything, but I think there is a chance of trying to reduce certain injuries if we can understand maybe when they occur and to what extent, regarding magnitude and rate of loading, frequency, things of that nature. So that's one thing. For my personal, I guess, journey of just intellect and continuing to grow, it would probably be, right now I'm just really into this process of like truly refining my skill set and ability to kind of understand what happens at a deeper level. So it's like right now I'm really big into looking at these knee pathologies and knee injuries, and also tendons. But I want to kind of like merge that. It's like that's the middle. Like I think I have a good grasp on it, but it's what happens from a biomechanical perspective. So understanding the physics of things, moment arms and momentum and impulse, all of those things impart the forces, the magnitude, the time, the duration. Those are going to change the biological tissue, but then also understanding the cellular response of that as well. So like both of those things buttress the actual presentation of the pathology. So if I can understand, the cellular makeup and then the physics makeup of what's happening, I think I can have a better, and even just this foundational grasp as to, okay, that's why this particular intervention process seems to be a little bit more beneficial. And I can draw these commonalities amongst different types of exercises or really just interventions, right? I think I have a grasp on the principles, but again, getting to more of like those root level entities and domains, I think is where I'm kind of headed right now, because that'll allow me to formulate a more coherent and pragmatic process going forward. And then, I think our team and Eric Schmidt is really, he's really phenomenal at like this energy systems development. So like this bioenergetics thing is fascinating. I'm not as far down in the trenches as he is right now, but I think there's something just understanding and pulling back the layers in regard to the metabolic capacity or fatigue resistance of certain tissues and their ability to have capacity. So can they sustain this output at a particular intensity over a duration of time for this frequency of how many games that they have to play? And so, you know, understanding that at a more cellular level allows you to probably create and construct a little bit more of these effective protocols for that particular tissue. So those are like the big things. Hopefully I answered all your questions right there.
Yeah, totally. And I'm sure that after this, there's a lot of people who are going to want to learn more from you. And you've put out a ton of really good educational content. Would you mind talking about where people can, learn something? I know like with Rehab to Perform, you're contributing with that. You've done some stuff for clinical athletes. So what resources are available online for people to, learn more about what you've contributed to the field?
Yeah, I try to post some things relatively frequent on my social media on Instagram. So it's Dr. J Fit Boyd, and I'll try to post brief, little, I guess, like mini lectures, if you will. I mean, 5 minutes or so of me just kind of having two slides up and talking about particular concepts, but also a lot of different podcasts such as this, but even a few presentations with. Clinical athlete, level up initiative, the online human performance by Rebel Performance, and then a few other kind of things that I'm really working on right now as well is with the science of sport. So contributing to like their mini course series, and I'll be giving a lecture series that's about 2 hours long that's covering tendinopathy. So to be lower extremity tendinopathy, kind of what is the science behind it and what are the current trends in regard to intervention processes. And then the last thing is just being a lecturer for R2P Academy, as you had mentioned, where I used to work in outpatient physical therapy rehab. So, we have a course where we are really just trying to disseminate information about what does it look like to really go from plinth to play, and what are some considerations, not really giving people all these answers because we don't have all the answers, but it's really like giving them enough information and the principles and the platform to be able to ask better questions and seek out things that maybe are a little less wrong, and instilling in them the confidence to really be the ones that are able to help athletes and people that are physically active get back to their desired and required activities.
Yeah, well, I'll definitely post links to all those resources in the notes for this episode. And I appreciate your time. I mean, like I said, I've been wanting to talk to you for a while, and I'm looking forward to actually looking at some of these resources for myself. So I'll have to, when I put them in the notes, I'll be one of the first people to purchase them.
I appreciate that. Thanks a lot for having me on, man. It definitely means a lot. As I mentioned offline, somebody that I definitely looked up to. I mean, read your stuff all the time, so it's been a pleasure. Always learning from you. So I appreciate what you've done for the field too.
Yeah, thanks so much.
As a thank you for listening, we'd like to offer a 10% discount on all products at resilientperformance.com. Please use promo code PODCAST at checkout. That's PODCAST. And I also encourage you to sign up for our mailing list to receive exclusive articles only available by signing up. Thanks for listening.